Good morning and welcome from all around the world to Structural Heart Life Cases, broadcasting directly from the Cardiac Catheterization Laboratory at Mount Sinai Hospital. My name is Pedro Moreno. I'm Professor of Medicine, Interventional Cardiologist, and I will be your moderator today. We'd love to hear from you, so please send us all your questions directly from the website or on YouTube. And remember, you can watch all these previous cases at ccclivecases.org. Now we have a fantastic case for you today. Let me transfer you directly for the live case to the cardiac cath and Dr. Sharma and Dr. Kinney.
Okay, good morning with my team here from the cath lab. Kinney on the left side, Dr. Gilbert, in the behind, and Dr. Sahil Khera. He is now the director of structural heart intervention at Mount Sinai. Had been here for this is the third year start, and then we have our fellow Mahdi. So, and of course, rest of our cath lab team, and on echo, we have Dr. Larakas, and we have anesthetist, our cardiac anesthesiologist, Dr. Eric Fried. So with that, we want to just share one. We did have a e-blast announcement of a different case of the bicuspid valve, but that patient was admitted to other hospital with pneumonia. Hopefully in 2 months, when with the next structural webcast, he will be ready. So we had a different case, another challenging patient with a severe aortic stenosis, and we'll go through it. Of course, this patient has a prior bypass surgery. If we can have our slide quick presentation. These are our faculty involved with their disclosures. And this is the case number, our 42, 75-year-old male, presented with heart failure symptoms, had a prior bypass, has occluded grafts, and now presented with severe aortic stenosis. He had been progressed to AS over last few years. His CABG was done in 2012. And we did the cath today, basically showed 2 grafts open, which we knew, LIMA to LAD and SVG to ramus, and still have a native circumflex disease, and that actually become very important, particularly when we start working with these valves, patients who are CAD. And I'll briefly touch about the complete tower in the end of my presentation today. But goal here is today, patient with a severe aortic stenosis and a normal ejection fraction for the purpose of tower. So this is the AS studies have been done. I think we should go more live with a high gradient. We can put actual pictures now. If we can put an echo on the main screen. Yeah. Stam, you want to comment on it?
Yeah, so this
anything unusual?
No, nothing unusual. This is parasternal long axis view, normal overall LV function with some posterior hypokinesis. As you can see, severe aortic stenosis with a lot of calcification, no pericardial effusion, normal RV function, no significant AI, minimal AI. This is the short axis view. Again, calcified aortic valve, no much motion, no much aortic insufficiency. This guy had a difficult images here on the table, lying flat, but as you can see, normal LV, normal RV, no much AI. The gradients were 55 peak gradient, 33 mean gradient. The CT saw calcium of 1900, so that can explain severe AS by both echo 0.8 centimeter square and by CT was 0.9. So that's it for us.
Perfect. Today. Very good. So now if we can go to the coronary anatomy, go to the angio now before we go on. Sahil, you want to move through this? Yeah.
So this is the native lab. There is osteocircumflex disease. There is a graph. You can see there's.
No, it does not work.
No.
Speak a little louder.
Yeah. What I'll say, if you see here the coronary anatomy, left main is non-obstructive. There's instant restenosis of the proximal circ. Is a 95% lesion. So you see the OM1, which is 95%. LAD, you have a LIMA attachment mid to distal. Looks like the distal anastomosis is good. It's a nice competitive flow. You see the RCA filling from the left system, essentially telling us that RCA probably occluded, and we know the vein graft of the RCA is occluded. This is a ramus slash diagonal graft that is patent. This is the native right coronary artery. multiple stents with IVBT he had, but that was all occluded now, and this is a LIMA that has a nice flow, which we saw from the native. That's where we are. This is the aortogram we have right now. Yeah.
Okay, so let's go back to our angio. So we go, slide presentation. So this is our angiogram. Now we go back to our slide presentation. So continue. Good. So we talk about echo. Now CT. Gilbert,
so yeah,
talk about
so this is annulus around area 375, mean diameter 22. LVOT is a bit smaller because of hypertrophic LV. You can see mean diameter around 21, area 328. So I think it's one consider we can talk about later is, how do you position this valve to avoid any conduction abnormalities, because you'll be quite oversized relative to the LVOT. Next slide. You can see the sinus of salva and the STJ were quite generous in this particular patient. Next slide.
Can't hear anything.
Okay.
Next slide.
Yep,
Okay.
yep.
You can see this patient has grafted, but we can talk about coronary access later on. In terms of left main height is quite tall. In terms of the circ lesion, also you can see that no major bulky leaflets. Next slide.
Yep. The coronary heights are good.
Yeah. So access is pretty straightforward here.
Yeah. And and we decided on the right side.
Yes, the right main access. Yeah. Next slide.
Right. Arch anatomy.
So arch anatomy, we actually did place a sentinel, and Sahil, can you comment? Your microphone is working? Or? No. Okay.
Is microphone working yet or no?
Yes, yeah. It's
Okay,
working.
go ahead,
Can you
Sahil.
hear me, Dr. Moreno?
Yeah.
Yeah, very good.
Okay. So this is looks straightforward on the CAT scan, but the ascending aorta is very short, so becomes very challenging to maneuver your Sentinel device. So we parked it actually in the subclavian.
Can we go back to the angio, please, to show the...
Yeah, go to the angio.
So the problem is a very short ascending and a very broad, wide horizontal part. So it makes maneuvering the device very hard. So we parked it in the subclavian, which does provide around 20% protection to the the vertebral circulation. So your common carotid at this point is.
So it's not in the left internal carotid; it's in the left subclavian.
Yeah.
Okay. So vertebral we protected, only not protected is the carotid, and many times when you put in the carotid, you don't protect the vertebral.
Correct.
Yep.
So that's where we are. So go short anatomy, and and I know there is still a lot of room to come up with the new devices for the cerebral protection, and they're starting the randomized trial at present. Boston Scientific with the Sentinel with the intermediate to high risk patients. We are using as many as possible. When it's appropriate, we do use Sentinel device in patients, and clearly the data show, and our personal also, where we have used it, overall incidence of CVA goes down, but more importantly, the disabling CVA really goes down by using the Sentinel device. And we use in about around 62% of our cases. Okay, we go back to the slide now. Okay, so last the presentation should be the overall this patient with the low risk, and we decided to use the Sapien valve, and the size wise will be issue, and particularly where to place because of the narrow LVOT. Yeah. Okay, so Anu, we are ready now.
Okay, we'll just cross. We have a AR2, and we'll use a straight Tarumo. In graft cases, I think when you're going with a AR, you have to be very, cautious that we are not engaging any grafts.
In the meantime, Dr. Sharma, tell us a little bit about your approach
No,
in
no, no,
patients
wait,
with
don't go,
coronary
don't go.
disease and TAVR.
Yeah, I mean, clearly, this is a big issue, and I know that everyone, we have two major valves, self-expanding with the evolute and the balloon expandable. So basically what the data are very clear, that acute occlusion happens, of course, selected patients. We select patients who could go for surgery as a low coronary height, less than 9 millimeter or 10 millimeter, they should go for surgery because you don't want to have any complications. Some cases, of course, you do a left main protection. But the key, more important issues remain is that acute occlusion, if happens rarely, maybe 0.4 to 0.8% of the coronaries. Keep going. Yeah. Happens acutely.
No, we want to show the hemodynamics.
Oh.
Can you show the hemos?
Let's zero first. Let's zero.
Yeah, 3-0, yeah. So
3-0 and let's show the hemos.
That, so in those cases, acute occlusion little higher with the Sapien compared to evolute. But more importantly, the subsequent engagement of knowing that it's the Sapien sits below the valve. Coronary engagement is very always possible compared to the evolute. I know there are some data shows maybe okay, but many registry data have shown very high incidence of failure that you cannot engage the coronaries. And we know that we do a lot of issues in terms of going through the using guideliner, come around, and our paper did speak about this issue of the coronary engagement in aortic stenosis. We have publication in JACC a few years ago, and Anu is developing the TAVR cathode app.
We've shown it a few times.
Yeah, we have shown it a few times, and just basically giving the examples. And they will now, with the new version, will have many cases how to engage the coronaries, and that is more important for the evolute compared to Sapien. Yeah. Okay. So let's go cross. Don't say anything. Yeah. We are ready now. So AR2 went into the ventricle. And this case is important. You saw that right is gone. Proximal circ has a 90% ISR.
Correct.
So patient will require intervention. Of course, you need to decide whether you do a FFR guidance or some that how. But as we know, the from recommendation point of view, that patients with a significant lesion, 80+%, the recommendation appropriate criteria point of view is that it's okay to go ahead in the major vessel, and this is the major vessel. So you don't need, because we know one, you cannot do any stress test. Secondly, FFR with adenosine could be trouble, but post TAVR will be less of an issue. But key is that it will be appropriate when patient if remains symptomatic. So we don't not based on the non-invasive testing, but patient will improve after this TAVR. But if it still remains symptomatic, comes back because there is a large area of ischemia. Right does have some LV dysfunction, I mean inferior wall, but large infralateral area, inferior area. So this patient will be still symptomatic from ischemic point of view, because otherwise very active. So it will be appropriate these cases that we bring back them for the stage intervention.
Excellent point. This is very, very important with the most common or the most recent appropriateness criteria for the TAVR, which is now included in this document. No cases are rarely appropriate. All of them are either moderate or appropriate. Yeah.
Right. Yeah. Okay. So now tell us, keep saying what you're doing now. Yeah.
We cross with AR2 with the straight Tarumo, then exchange it to a pigtail, and now we have the confida wire. So these steps are very important, that we have to have a pigtail. So we have the confida wire that goes to the apex.
Now my question is, do you really need to dilate or just go with the valve?
No, it's pretty calcified, Dr. Sharma, so I think we should. I know that there's a discussion about that. I think there's some early evidence that there was a recent paper showing that if it's underexpanded, the S3, there might be more risk of a halt and other ingredients. So I think it's reasonable to pre-dilate.
So I think the goal should be that you avoid post-dilatation. That's the key.
Correct.
So do whatever need to be done pre, whether it's a Sapien or evolute, but the idea should be that avoid post-dilatation. Because that is where all the stroke and all these things have shown to occur.
Pace 150.
Yeah. Because BAV alone, very low incidence of stroke. I mean, we have been, if we take our data of the BAV for last 10 years, having more than maybe around close to 2,000 BAVs, stroke rate is less than 0.2%. Very rare.
What did you put? You put half and half? No,
good.
Doesn't move.
Okay. Valve is ready?
Can you walk it out, Dr. Sharma?
Walk it out, yeah.
Okay, watch your feet, Sahil. The angle is pretty steep on the coplanar view, so we're going to go there now.
Little negative.
Why it is not coming?
Little negative.
I don't know, this dye is horrible. What dye is it?
It's 1 second, guys. No.
Okay.
Go up a little bit. Good. Negative. Yeah. Good.
Good. Okay.
What size balloon we used?
Yep. Which size? Yeah.
20.
20.
20.
20.
That's 90% of our cases is usually 20 balloon.
Yeah.
Okay.
Okay. Check orientation.
Okay,
Confirm.
check orientation, confound with the skirt facing down, ventricular skirt.
Gilbert, you want to comment about minimum versus average for deciding your predilation balloon?
Yeah, so I think it's a good point about what size you pre-dilate. So with the Evolut system, we typically go by the minimum diameter. With the Sapien, we try to basically do gentle pre-dilatation to avoid QAI. So in this case, 23, we typically use 20. 26, we usually around 22. Even for 29 valve, we use only around 23 balloon to pre-dilate just to get the valve across. Because what you don't want is to scrape across the native valve and cause debris embolization.
Small vessels.
Or if you have issue crossing the valve and causing obstructive outflow and cause hemodynamic decompensation. Those are the things you want to avoid.
So we are facing some resistance. So if that's the case, always go below, check. So wire position is very important at this time. So we don't lose the LV wire. Okay.
Dry gauze, please.
Other question is that the wire giving a trouble, your crossover wire?
No, but it's not in the sheath outside. 1 second, 1 second.
Exactly.
Low mag.
Yeah, low mag.
But there was not much calcium, right? On
One
No, it's a
second, one
small
second.
vessel.
iliac.
Wait. Hold the wire, hold the wire.
Yeah.
Okay.
So always want to see
So
how
we
your
just,
valves coming up.
yeah.
Yeah, so the smaller vessels is harder to advance because the E sheath has to expand. So I think that's a little nuances that people have to recognize that.
Good.
Thank you.
Okay.
Particularly in the cases of 29S3.
Advance.
So
Okay.
because
Yeah,
16.
go. Okay, advance the wire.
That's fine. I'm running the floor.
Okay. I'm just going to bring the balloon back.
Yep.
Load. Okay, advance.
Good.
Yeah, good. Now rotate the small wheel towards us. Good.
So now the balloon has been loaded, or valve has been loaded on the balloon.
Yeah. Okay, now go with your Raj. Complete
So one
flex
thing to-
catheter.
Yep.
Yeah.
One thing to watch is make sure avoid interacting the Sentinel, so it's good. We're crossing the valve, Eric. This is the implant view now.
You have to do some unflex.
Yep.
Okay, right? Advance the wire.
That's fine. It's in there already.
Came out. Yeah.
Yeah.
Okay.
Okay, so now we're going to talk about, we're positioning the valve. The pigtail is already at the bottom of the non-cusp. It is already, Dr. Kinney. I did it already.
Okay.
Just push a little
Okay,
bit
some
more
dye.
to get to the bottom. It's not quite the bottom yet. Yeah.
I think you're
almost.
okay. No?
Yeah, it's almost there. Yeah, that's fine.
Otherwise, you have to pull back and
Yeah.
advance
No, but
it.
you have landmark. You have landmark. You can see
be okay.
the top
Okay,
of the top
some
of the
dye?
RCA stand is actually quite.
Yeah,
we
you're
can
good.
go a
You're
little bit
good.
more aortic, probably.
I'm
if you-
pulling
yeah,
back.
good. Okay, that's up. You went.
Yeah,
you went
that's
quite a
good.
bit. So this in this case the valve has no parallax, so you have that what they call the
Okay,
lucent line.
180.
So what we do is we go with a 180 and just give the dye. Don't deploy yet.
Inject.
Looks good.
Okay, stop.
Yeah. So once we have position, that is
Very good.
everybody happy.
Please.
Yeah.
Okay, 180. Okay, I'm going up. Okay, good. Full inflation.
7.
I'm about, no, it's only 6.
Okay. So we check the atmosphere and we inflate to see. Keep pacing.
Okay, we
keep pacing.
continue pacing until the balloon is out. Okay, stop pacing.
The patient
Come
recover,
down.
please.
Yeah.
Let the patient recover at this
down.
time.
Come down here.
So you can see the valve had no parallax at the nasal deployment, so we like to implant a little bit high, as we mentioned about the small LVOT, to avoid conduction system issue. So let's see the final depth here with the aortogram.
Ready?
Yep. Ready?
Okay, inject.
Perfect.
Beautiful.
Nice.
Very nice.
Okay.
Okay. Okay, let's give Sam some room to look at the echo.
So we still leave the wire in case you need to post dilate with
Correct.
putting additional contrast.
So you can see with the sinuses, right there, it's on 80-20 deployment,
Yeah.
which is at least what we like to do. We sometimes go even higher in the context of right bundle branch block or calcification of the annulus and LVOT to make sure. But of course, you have to make sure you don't end up injuring the sinotubular junction. So you have to measure the sinotubular junction, the sinus height
That's a
as
wire.
well.
Put the echo on
Can
the
you
screen.
show the echo full screen instead of the fluoro?
Yeah.
Speak louder, Stam.
No, you cannot hear it now.
Oh.
They're different.
So what he's saying is in a good position. What you're seeing is a central AI with the wire, and there's no pericardial effusion.
Yeah.
Now let's show some short
No,
axis.
he has it, yeah.
Yeah, that color you see is just the
Yeah, it's a wire.
central. It's transvalvular.
Okay, yeah.
That's a short.
That's the wire again.
Yes.
Looks good.
Take a gradient, take that, please. Put some color there, please. Bring it down, yeah. Bring it down to the aortic valve. Bring it down to the aortic valve. Okay, take that, no AI. Okay, put some continuous wave, please. Okay, take that, please. Okay, so everything looks good.
Okay. So
right, great.
let's go back on fluoro again.
So we'll
So
just
now
take
we
out
can
the wire.
take the wire out, right?
Yeah, take the wire out.
Okay.
Yes, good.
Yeah.
Completely unflex, and you can bring it down.
Okay.
Okay, to non-parallax view.
Okay, that's right.
They don't bring.
Okay, yes.
This guy is unbelievable.
Good. So what are we going to do? We don't need to do another aortogram because you
No.
already have
Yes, that's right.
good aortogram. You already have done the
Yep.
the echo. So both are consistent. That valve has
Sentinel.
fully expanded. Now the hemodynamics, which we used to do routinely, recrossing, kind of been avoided now. I mean, we have eliminated that in majority of our patients, unless it's a trial patient.
Yeah,
then we
or maybe
do.
a valve in valve is small
In the
valve.
valve and valve definitely is more because you can always post dilate and so. And now we are ready to take the Sentinel down. Okay. So I'll keep talking about what are we doing now for this?
So the first filter is your subclavian filter, which is coming out. Totally unflexed the device,
Okay.
and then you start withdrawing your main filter there. The point here is you wanna push your sheath on top of the filter rather than squeeze the filter back, because that can shower the debris up.
And do we routinely see that is there any debris?
Yes, we try to check
Sometimes
those
so.
afterwards. Yeah.
Yeah, I know in the overall Sentinel trial, 98% time you're able to get debris. They actually had some of them even aortic valve tissue even.
Yeah.
Not only calcium, aortic valve tissue. So the embolization, of course. So with that, now what we're going to do is
Closure. Yeah.
Closure, you already have a pre-close?
Yes, we have one pre-close.
Oh, one pre-close.
One pre-close, yeah.
So then pre-close and angioseal, or what will be the goal
You
here?
will see how it looks. The vessel was
Go inside.
5.5.
Yeah.
It's a small vessel, so let's see how one pre-closure looks.
Okay. Any question?
We have no questions from
Okay.
our audience.
Yeah. Okay. So we can go back while the closure being done. We can go back to our slide presentation, and for next 10 minutes.
Body protamine.
Yeah. Okay. Let's see what happened to the slides. Huh? 3. Okay. maybe the collateral. So okay, now. Let's see, this also slides got stuck. Oh, okay. Good. So what we'll do is bicuspid. Since this was our case, supposed to be the bicuspid aortic valve stenosis, because a lot has been said recently, one of the common disease. And these patients, we know that once you follow this bicuspid patient do have trouble in the future. And therefore any patient, and it's also congenital anomaly, it is familial. So every patient with a bicuspid, recommendation is the kids should be also studied with the echo and follow them because they develop ASAI. Now question is, it's a very heterogeneous group of patients with a bicuspid compared to tricuspid. It's an embryogenic abnormality, the way whole the valve being formed with the aorta and pulmonary. So, and this bicuspid anatomy has a multiple features. So one classification came about a decade ago by Sievert's classification, which everybody uses that. Type 0, 1, and 2. It's based on the RAFI. Gilbert, you want to comment on this a little more?
Yeah, I mean, most common is the type 1. That's what we see in the in the operating room. And we see that actually also in the TAVR literature as well. It's very rare to have type 0 because they present very young. Type 2 is also quite rare.
Right. So most common is type 1. It can have it's one RAFI. It could be in with the coronary cusp, non-coronary cusp, left and right cusp, and so. And then they have a Gilhavi classification. I didn't know much about this. We actually uses additional with the commissure involvement. Do we use that? Although most of the data are just talks about the Sievert's classification.
Yeah, Sievert's is the most common because at least the surgeons and the cardiologists can speak the same language. I think what Hassan's classification more is in terms of the TAVR feasibility, looking at the commissure and whether how calcified the fusion is. So it's a different kind of approach to looking at it.
Yeah, but key is that the type 0, much younger, usually they go for surgery. Type 2, which is a 2 RAFI, it's also very uncommon. It's usually single RAFI, but which way it happens is a different story as shown here. So type 2 is the most common one. I mean, type 1 is the most common. And this actually CT. There is corroboration with the CT based on that. So question is, compared to our tricuspid aortic valve, we have done very good with so many randomized trials. But bicuspid requires special attention. Why? Because of few things. One, where the calcium is. Additional calcium on the RAFI as well as in the leaflet and LVOT. And more important, which common disease process is the aortopathy, that dilatation of the ascending aorta. And third is, since the bicuspid valve, aortic stenosis present at younger age, you need to think about what to do. In these cases, on a long run, let's say you decide at age of 60, low risk, and you want to do a TAVR, and then question will come, what you're going to do later on. And more importantly also, the coronary engagement. So multiple factors comes in. The issue about the aortopathy is very important, and this is what many times decision making happens in these cases, that patients who otherwise may go for TAVR but has a dilated aorta of 4.5, 4.8 and plus should go for surgical replacement. And as I mentioned, with the RAFI, calcification level, age, all those come into equation. The more important is the anatomy of the bicuspid valve, the way it is. Many times very elliptical structure, not a circular, even if you put a valve. So it is always associated, or paravalvular leak more than mild is common. At present, I would say PVL more than mild is unheard in the tricuspid valve.
Yeah, it's. I mean, in our center here, like mild is around like 10% at most. It's actually even less than. Site report less than the trials.
Yep. And in the bicuspid, because of incomplete apposition, valve migration, of course, that could be the issue, and more pre and post dilatation required, and that's why you also have a higher pacemaker implantation. This is a coronary access, as we mentioned, that very important because of the young age of these patients. So this actually have put in this paper about the review that favorable for TAVR, favorable for SAVR, and actually in the TAVR, although we talk about the Sievert's type, truly no study has correlated the outcome based on the Sievert's. Although they have calcification of the RAFI and leaflets, which I'll show the paper, but otherwise feeling is that TAVR is good for type 1. So why TAVR cannot be done for type 2?
I think, well, type 2 is also very rare. I think, we just did one type 0 last week of the high surgical risk patient. So that's only we've done one this current year so far. Type 1 is most common, as you show in the table. It's really how calcified that raphe is, because that becomes a spear when you use a valve, or that's where the PVL is. I think that's what you mentioned about have to look at it, the anatomy case by case.
Yep. Now, Anu, any question comes up when with the age and the bicuspid valve versus tricuspid? Age correlate, the age come into equation. We know that bicuspid usually favors for surgery, particularly young age. Any particular scenario where you feel that even bicuspid younger patients should go for TAVR?
No, I think only if there is a high surgical risk, like we did that last case. And also I need to tell, even technically, it's challenging.
Yes.
Crossing the valve, getting the, positioning the TAVR valve itself, and BAV. We have to make sure we have BAV and that calcified raphe has been broken. We have at least 2 cases where we know, you'll have some PVL in the side, which is always our concern. So unless they are, surgically deemed high risk or extreme risk, and the surgeons tell us that patients should go for TAVR, these patients should go for surgery.
Okay, very good point. So now they actually, in this field, were evolving one first paper in this field of the bicuspid aortic valve from the TVT registry by Raj Makkar, published few years ago in TCT, and then came in JAMA paper. They compare bicuspid 2691 with the 2691 tricuspid from the large TVT registry. And that is the first formal comparative data published on this field of bicuspid and versus tricuspid, and very interesting. As you can see, once your case matched, bicuspid and tricuspid, their mortality, particularly is no different. Rather, you can say numerically lower. But what is the clear cut came out is your stroke rate. Definitely higher stroke rate in the match group with a bicuspid versus tricuspid, and I'll come back to that point. And second is the pacemaker. As you can see, the higher pacemaker. So 2 things came very clear, and also then subsequently the various data in terms of the PVL. So all those 3 things, pacemaker and stroke and PVL, all 3. Now then there's another study. This was with using the Sapien valve, balloon expandable. Then the self-expanding, we also have the data about those patients and actually correlated where the calcium is and how patients are going to do. And you can see here, once you have calcium into the raphe as well as leaflet, which is about 26% of cases, the very high event rate of mortality at 2 years of 26% compared to 5-6% otherwise. So that is where once you do your CT angio and you see that calcium raphe as well as excess leaflet calcium, that patient should go for surgery.
Yes.
We should not do. So this is a very informative paper by Yoon and understanding that which case are ideal. So if there's no calcium, raphe or leaflet calcification, good for TAVR. And of course, the calcified raphe, only one calcium, raphe or in the leaflet, which is the majority, okay. But if you have both of them, they should go for surgery unless, as Anu mentioned, if they're high risk for surgery. Now, actually, for the Sapien, we have a lot of other registries. We have ACC TVT registry, then Waxman's low risk registry of 61 patients, and then BAV TAVR International Registry and Bavard by Teche. So clearly, you see the Sapien used about majority of the bicuspid valves. Also, we have the separate TVT registry of the Evolute, but many of these registry have used Sapien in about 3/4 of cases. And overall, the data which I mentioned earlier still holds true, and now it's about 8.5% event rate at 1 year. So now this is the ACC TVT registry, bicuspid versus tricuspid using Evolute valve, and the message was about the same. In this group, actually, there was no difference in stroke. So this comparative data of using Evolute from the TVT registry, which is more recent, there was no difference in the stroke rate, which we knew earlier point. And these are the individuals shown here, and so overall, the bicuspid versus tricuspid, good outcome. You do have a slightly higher, as you can see, the mild PVL, more with the bicuspid versus tricuspid, and of course moderate to severe is very rare, but definitely those things we need to see along with a higher need for pacemaker. So lastly, and this is actually, this I said, Waxman's group with the 61, they actually always show excellent results. The low risk TAVR, and now for the bicuspid, as you see here, only 30-day data. There was one patient had a TIA, there was no mortality, 13% pacemaker. Within there, 74% got the Sapien and 26% got the Evolute in this group. And the need for pacemaker in the Sapien group was about like 6 or 8%, and with the Evolute group was almost like 20+%. So very high incidence of pacemaker. Overall was 13%, and paravalvular leak was about 1.6. Now also interesting, the 30-day CT they did, and they found the hypoattenuated leaflet thickening in almost 10% of cases, although none of these patients have a clinical event. But we know that 1 month is too small. We need to follow these patients for longer term. So another important point which has been done, this is from China, brain injury after transcatheter replacement of bicuspid versus tricuspid. And they took patients, about 200 patients with the bicuspid and tricuspid, very methodically did the baseline and follow-up diffusion MRI, and show number of lesions, total number of lesions with the BAV versus the TAV, and put it together in a nice picture. BAV type 0, BAV type 1. So both of them had a higher incidence of the number of lesions, the volume of lesions, and the size of lesions. So clearly, BAV does give rise to more brain lesions. Now, stroke rate, 2 patients stroke in both the groups. So the actual stroke was not different, but much higher. The volume of the lesions as the size of the lesions in this very carefully, very nice detailed analysis of the brain injury they call TORCH trial. So this basically say BAV patients may encounter more severe brain injuries, not only due to greater number of lesions, but also due to larger lesion size in the early phase after TAVR. So clearly the author mentioned that every patient, once you're doing BAV, make an attempt to use a Sentinel or cerebral protection device. So very important. So this actually, I want to conclude this whole issue about TAVR for bicuspid aortic valve. A lot of things are happening, some plus, some minus. More importantly, I like this editorial by Colombo that there is no randomized study. But yes, we know that some of them do well. But our question is, you have a nice short-term outcome. We don't know what happened 4 or 5 years. So, and most of the studies at present, which we have shown here, either case-made match registry from the TVT, or they were the nested registry in the partner and Evolute low-risk trial. So there were one arm only, and of course selected patients were done. So question is, how would you answer this, whether in routine run-of-the-mill cases, the TAVR is as good as surgery in BAV patients. So there is clearly no randomized trial, but I think there is a lot of momentum, is just like for valve-in-valve. The same way, so that is one group where we need a randomized trial, valve-in-valve versus valve-in-valve TAVR versus surgery. Or second group will be the bicuspid, low to medium, unless anatomy is prohibitive, randomizing them to TAVR versus surgery need to be seen. So this actually have very nicely put it, this review article, that basically that what we know, that it's a TAVR and bicuspid aortic valve, feasible and safe. 1 year mortality similar to with a surgery as well as tricuspid valve. Better results with newest generation valve. A CT scan is mandatory for procedure planning. Calcified refen, highly calcified leaflet associated with poor outcome should not be done. Warning that low but high risk of stroke, higher risk of pacemaker, and low but higher risk of annulus rupture, particularly balloon expandable, and higher risk of mild PVR compared to surgery. Then remaining question, anatomical features, optimal CT sizing, type of valve based, prosthetic valve durability, thrombosis, and of course, what happens to, you have done a TAVR. Now what will happen to subsequent aortopathy? There is a question, people say that the bicuspid valve have aortopathy because of the directed jet. And once, let's say it was 4.6 centimeter aorta, but now you have done the TAVR, it will be more central jet, maybe that 4.6 will remain 4.6. This is what has been reported in the literature. And of course, we need to have a long-term follow-up and particularly a randomized trial as mentioned here. So multiple factors comes in considering these factors when we decide patients for bicuspid valve TAVR. And I would say that at Sinai, our personal experience has been that probably about 30-40% gets the TAVR and remaining go for surgery. Anu and I'll ask both Gilbert and Anu make that comment in their practice. But my practice basically is only 30% of the BAV patients because they present early age, they go for TAVR, but majority of them go for surgery.
Yeah, I mean, most of the younger patients, Dr. Kinney, you and I and Sahil have seen are younger patients but on dialysis or major comorbidities. So those ones, you see the bicuspid, but clearly they could be high of previous cardiac surgery. So those ones, we go by case, and we carefully, like what you said, size and deploy the valve, in an optimal manner. But we did have seen some octogenarians come in with, not true bicuspid, but partial fusion. So kind of what, Hassan's classification, they have a little bit of fusion, but not maybe functional bicuspid. Those, I think, was reasonable to treat. And we have actually gotten very good results. In fact, we're now doing a post-CT study, look at the morphology and the valve expansion of these patients.
Anu?
No, I think everything has been mentioned, and agree whatever we say. We just have to be very cautious and case by case.
Yeah, and more important, younger patients, if somebody can do the Ross procedure is actually great. And actually we have our very star aortic surgeon, Dr. Ismail Al-Hamamsi, and many of these younger patients have gone to the bicuspid. Actually, I can tell you in last 1 year, at least 5 of them we have sent to him, and everybody got the Ross procedure.
Yes.
And great for long term for those patients. So now I just wanted to say very simple, this concept of the coronary disease, like here, we just came up that what you do, patient who has severe aortic stenosis, there is a trial on its way, because we know that CAD is presented almost in 50% of cases. Should you treat or not treat, there are data or either way, but more importantly, the trial is taking off, and we are part of the trial. We'll be starting in next few weeks. I think we are ready to start. That is complete TAVR. And this is a patient with a SAPIEN valve who has significant coronary artery disease. After your successful TAVR, either you do complete revascularization, do the PCI of all lesions, or you do a medical therapy and follow up to 3 years. And clearly, this is the primary outcome is composite of cardiovascular death, new MI, and ischemia-driven revascularization or hospitalization for an unstable angina or heart failure. Very important trial, because a lot of people believe once you have a TAVR and CAD, just take care of the TAVR, everything will be set. Because there are some data to support that notion, but now we are ready to start this trial for this purpose. So just coming back to our take-home messages and conclusion of the presentation, increasing number carefully selected BAV patients are now undergoing TAVR procedure with excellent short and 1 year outcome. However, there have been reported higher incidence of stroke, PVL, permanent pacemaker insertion versus TAVR compared to the tricuspid aortic valve. There has been no randomized clinical trial in this patient group. Second, heart team discussion and proper pre-procedural planning, including detailed CT scan analysis, are essential for proper case selection and lower procedural complications of TAVR in this BAV patient. Low to intermediate STS risk BAV patients with unfavorable valve anatomy and or dilated aorta are best suited for surgery. So go to our 3 questions. Following are the favorable factors for better procedural success of TAVR in BAV stenosis, except use of Sentinel device, minimize pre and post procedure dilatation, proper valve sizing, calcified raphe and calcified leaflet. As you see, those are the ones do badly once you have raphe and leaflet calcium. Second, following are the important considerations selecting patients for TAVR for BAV stenosis, except age, STS risk, Sievert's anatomical group, aortic root size. As I mentioned, Sievert's is used, but really has not correlated in any study, except there's the separate, the leaflet and raphe class calcification is different. Lastly, following is not the appropriate BAV patients for TAVR over SAVR. Non-calcified raphe, coronary height less than 10 millimeter, homogeneous moderate leaflet calcification, aortic dimension less than 45. Clearly, this is the patient who has a coronary height of less than 10. Higher risk of occlusion with the TAVR, so this patient should go for surgery. With that note, I'll stop here with presentation today. And they have already closed the groin.
Groin's closed,
yeah.
No.
Yeah.
All right, Pat.
Okay, thank you so much, Dr. Sharma, Dr. Kera, Dr. Kini, for such a fantastic case and the meticulous, careful review of such a controversial aspects of bicuspid aortic valve. Thank you, all of you, for joining us today. Remember, our structural cases are every other month. So our next one is going to be in September 14 at 9 a.m. Most importantly, later today, you will have this case to be reviewed extensively in ccclifecases.org. Thank you so much.